increased incidence. So this gastric carcinoma is a deadly disease. The problem is the diagnosis. If you diagnose early, then the prognosis is good. The late diagnosis leads to very poor prognosis, and patient has to suffer a lot. So early detection is key to success in the case of the gastric carcinoma. The carcinoma in the stomach is when we just to see that the most common site for having the carcinoma, that is the proximal part. Proximal part of the stomach means that portion which joins to the esophagus. So esophagogastric junction is the most common site. Almost the 60% cases, the site of carcinoma is that area, that lower part of esophagus and upper part of the stomach. And the 20% is in the distal area, means the pylorus and the first part of duodenum, and the 15% is in the body area. Okay, so the two are the common site: proximal stomach and distal stomach. Out of these, proximal stomach is more common than means 3 to 4 times more common than the distal stomach. So there is some clinical distribution has been found in the society. The patients coming from the lower socioeconomic status, carcinoma is common in the distal part. Understand? Means the patients from the lower socioeconomic status are most in the patient of the lower socioeconomic status, distal carcinoma is more common, while in the patient of that higher socioeconomic status possesses that carcinoma in the proximal part of the stomach is most commonly. So now move to the etiological factors. The commonest etiological factor for the CA stomach, that is the H. pylori infection. That's why maybe it is commonly found in that lower socioeconomic status. Patients with the pernicious anemia are very at high risk, and the continuous gastritis leads to atrophy and metaplasia, and deficiency and intrinsic factors, gastric ulcers that may have pernicious anemia. That patients are at high risk. The gastric polyposis, polyps, that is the the polyps are the small pedunculate structures whose growth is small. Usually these conditions are benign polyps, but the patient have multiple polyposis, multiple polyps in the stomach. The condition may be the pre-malignant, so that patients may be turned into that. Patients may turn into the carcinomas. When we discuss that complications and the sequels of the gastric surgery, we know that one point is there: the patients having the gastric surgery or the patient with the peptic ulcer surgery becomes more prone to develop the CA stomach. So this is the also important factor, maybe due to the reflex of that in that cases also, that the joining part, the anastomosis part, most commonly develop the carcinoma. That may be due to the exposing of that part of the intestine to that directly to the stomach. So that's why that reflex gastritis may be the cause, or the H. pylori infections may be caused. So the patient having the peptic ulcer surgery have 3 to 4 times more commonly found that convert the the case of peptic ulcers later on after surgery into the CS stomach. Cigarette smoking is common. Dust inhalation in the, especially in the industry workers like the cement factory workers or that marble factory workers. So inhalation of these irritant, these can develop the gastric carcinoma. And some diet, some specific diet, especially the using spirits or some special conditions, some carcinogens are there. So some it has shown that the particular the peoples of the particular area having a typical diet maybe have single conditions most commonly found. So that's why diet may be also an important factor, because it has been seen that in Japanese peoples it is more common in the worldwide, and because that they are having a particular kind of diet, and some part of the China, the persons also have commonly found that gastric carcinomas. Next, that clinical features. So before going to the clinical features, I like to discuss these classifications. There is two kind of the classifications. One, intestinal gastric carcinoma and diffuse gastric carcinoma. Other is the early carcinoma and advanced carcinoma. That is staging. So intestinal and diffuse carcinoma is the intestinal means when that the changes is occurs in the intestinal wall, in the gastric wall, in the GIT tract in the form of the polyps. And while the diffuse part is diffuse kind of the carcinoma, it is diffusely present in whole stomach, and one, it is not peculiar found in typical areas. Somewhere it is means not concentrated at eight area. It is diffusely located in whole of that GIT or whole of that stomach. And the early and advanced conditions, these are the two stages. So stages, early stages means carcinoma which has limited to the mucosa and submucosa layer, with or without involvement of that lymph nodes. Understand? Look, the good thing of that the carcinoma, the gastric carcinoma, is that it usually first spread to the nearby lymph nodes. Later on, it is spread to the nearby organs. That's why it is more easily can be diagnosed if patient is examined thoroughly. So the lymph nodes become that the abdominal lymph nodes and in the left supraclavian lymph nodes, Burkitt's lymph nodes. These are usually comes in the first place along with other symptoms. So the patients with the early carcinoma, where the condition, the carcinoma is limited to the mucosa and submucosa layer, with or without involvement of that lymph nodes. If the cancer is moved to beyond the level of the submucosa in the muscular layers and the nervous structures, that condition called advanced conditions. TNM classification, we know, we already had discussed in that chapter of the cancer, the tumor. The TNM is the tumor, lymph node, and metastasis. Three things we have to measure. So this is the TNM classifications. It is also applicable here also for that staging of the carcinoma. There are different staging: first A, first B, second, third A, second A, second, third A, third B, and fourth. So there are different staging in different staging. There are different conditions. Maybe there, just like in the first A, T1, N0, M0. First B, T1, N1, M0, T2, N0, M0. So these are the means that the classification, the TNM classification is also applicable here to know the staging of the carcinoma, which stage carcinoma, to decide that which kind of management is required to do. Now come to the clinical features. So in the early stages, usually it is asymptomatic and either little the symptoms of the gastritis may be there. Understand? So in early cases, either patient may be asymptomatic or having some symptoms of the gastritis. In advanced cases, there are so many features: early satiety, bloating, distension, vomiting, anemia, because the tumor frequently bleeds, so lost the blood, that may cause the iron deficiency anemia. If there is a mass, so there may be the dysphagia, epigastric fullness, because there is a mass, the size of the stomach is reduced, and having the sensation of the fullness in the epigastric region due to the mass. The involvement of the pylorus features gastric outlet obstruction that we discussed yesterday, that along with the pyloric stenosis, the cancer also may develop that feature of the gastric outlet obstructions. Varicose node, that is the enlargement of the left supraclavicular lymph node. It is an important features of that gastric carcinoma. And some not metastatic features that like thrombophlebitis or the venous thrombosis. The patient who the patient who have frequently these thrombophlebitic conditions or the venous thrombosis conditions may have that gastric carcinoma. The site we already had discussed, the most common site is the proximal part of the stomach. So the treatment includes that radiotherapy, chemotherapy, and surgery. So to decide the which treatment you are going to decide, that especially that depends on the staging of that cancer. We already had discussed this in these things in the treatment of the cancer. That first we had to think the patient's conditions. If the patient can in the first stage, early stage, then surgery is the better treatment to remove that affected part and do the anastomosis. Here the two kind of surgeries advised: total gastrectomy or subtotal gastrectomy. So total gastrectomy, where the complete stomach should be removed, and that anastomosis of gastrojejunostomy, or that usually the first part duodenum is also removed. So usually the gastrojejunostomy is good procedure. In the subtotal gastrectomy, the similar to the Bedroth second gastrectomy, where some part of the stomach is removed and the later is joined to the jejunum. So along with this, due to these conditions, have some complications also we already discussed in the previous chapter. So Roux and Y diversion is also best option, is a better option in the case of that gastric carcinoma if you are suspecting it in early stages. If your patient is in a late stage, then you prefer the palliative treatment for the patient, because if the cancer is advanced to the nearby structure, in that condition surgery may be not helpful. In that condition, to do the palliations to your for that patient's lifespan could be increased, and the difficulties faced by the patient, the pain faced by the patient can be reduced by the radiotherapy or the chemotherapy. That is, so this is the part gastric cancer we have discussed here.